Hi everyone, I hope you had a fantastic 4th of July weekend. For those who are tuning in from other parts of the world, I hope you had a great weekend as well. I'm Britt Fallon, I am the beauty director at New Beauty Magazine. And today we are going live for another New Beauty Talks, and this time it's with board certified plastic surgeon Dr. Larry Pollack. He is from San Diego, and today we are talking about breast surgery. So we're going to be talking about breast reductions, breast lifts, breast augmentation with implants, and also too some of the concerns that people have about their breast implants. We are going to talk about exactly what you should know about those so we can soothe your concerns. We can give you the information you need to make educated decisions. So as soon as the doctor joins us, we will get him in here. I see him here. And yeah, I hope everybody's having a great start to the week. The sun is shining here in New York, so I'm smiling. Oh. Just waiting to connect. Again, if you are joining us and you have any questions about breast surgery, feel free to drop them in the chat and we will try to answer as we go. And let us know where you're joining from. We're just waiting to connect. I think a lot of people go live right at noon Eastern time, so we've just waiting to connect here. I'm going to try to add him one more time. See if this works. Here we go. Hello.
How are you?
I'm good. How are you?
Good.
Good. Did you have a great holiday weekend?
Oh yeah, it was nice and quiet and no fireworks, which was good for the animals, I think.
Oh, good. I was in upstate New York, so we did have a few fireworks, but it was really nice. It was nice. I think we needed a nice little relaxing weekend right now.
Yeah, that's true. That's for sure.
Well, I introduced you at the beginning, but I see we have a lot of new people that just joined in. So this is Dr. Larry Pollack. He is a board-certified plastic surgeon in the San Diego area. And for those who don't know you, can you tell us a little bit about exactly where we can find your practice and how long you've been in practice?
Yeah, I'm at Del Mar Plastic Surgery with delmarplasticsurgery.com. I've been in practice for about 30 years. And my practice has evolved over time. We do a lot of breast and body work. We do a lot of facial work. We're seeing a lot more men coming in for things like gynecomastia and liposuction and eyelid surgery to try and stay and look young, which is why I set up another website called menopause.com for men who are starting to go through the life changes that start to happen after 50. So at menopause.com, we have health tips and life tips and travel tips and things like that. So that's sort of been incorporated as part of our practice towards our male audience.
Yeah, that's such a clever name.
Yeah.
I love that. So how have you been, you're in California, so how has the COVID-19 situation been for you? Have you been using telemedicine a lot?
Well, we've sort of always, in a way, used a little telemedicine, primarily for clients that live out of town. And so we've set up interviews, usually over a mail or texts, with them sending pictures so we can do an evaluation without them having to necessarily come in before they actually have surgery. But, with surgery, it's a little different than in medicine, in the sense that surgeons, for the most part, have to examine patients. We have to kind of see what the problem is before we can make a reliable suggestion as to what they need. And so certainly even during the height of the COVID, my office made a real attempt to at least follow up closely on our post-op patients face to face with masks and all the precautions to make sure that they healed properly during their recovery. But with new patients during the height of it, we basically just sort of postponed them unless they did want to communicate via email or something like that, so we could do a sort of cursory evaluation and then suggestion as to what they might need.
Okay. Yeah, I mean, I'm finding, talking to all these doctors that I'm surprised by how many people were relying on a little bit of telemedicine beforehand, and how
Yeah.
much, maybe for dermatologists too, for skin rashes, how much of it can be done,
Yes.
now
Yeah.
moving forward that we didn't know
Yeah.
before, which is really cool.
Exactly. And even post-op patients who might be concerned about a little redness here or there, they don't necessarily have to come in for that. We can take a look at it over the phone or via photos that they send and let them know, you better come in to be checked, or don't worry about it, it's normal. So we've always incorporated a little bit of that. But like I said, for the most part, for surgeons, I think sort of hands-on is kind of important to really know what's going on.
Yeah. So today we're going to talk about breast surgery, which is, one of the most popular topics at New Beauty. We get dozens of reader questions about this topic all the time. And there's so many parts to breast surgery because there's so many things you can do, so many options. So, there's augmentation if you want to go larger, there's reduction, there's a lift, and even more than that, and many different nuances. So I'd love to start by just asking about consultations, because I think this is interesting. If somebody comes to you and they're just like, I think I want to go larger, but I'm not sure, like, how does that process start? How do you, first figure out what the patient wants?
Well, it's interesting. In our practice over the years, we've seen two major types of patients. We have patients who come in who have been thinking about it for years, and they come in and they're timid and they're sheepish, and they're either just embarrassed or they think, am I being too vain? And those patients, it's interesting. They have a very realistic idea of what they want to look like because they've been thinking about it so long. And then the other kind of patient we get is the one who wakes up in the morning and says, I need a breast augmentation. And they come in that day, right?
Wow.
And they're a little more confused maybe about what size they want to be and what they want to look like and stuff like that. So fortunately, for almost 30 years, I've had my office manager, Kate Loeris, who not only understands the business, but she works really, really well with patients. Even after I do the consultation, she will pull out more information from them about what they really want that they may be either embarrassed to tell me or they forget to tell me after I've gone. And it really helps us get a good bead on exactly what they're looking for in terms of whether it's enhancement or reduction or whatever it might be. So it's a process because, you want to make sure that patients get what they want. Because, having to go back and change things is not only expensive for the patient, but is a nuisance. So we spend a lot of time really focusing on what do you want? Are we on the same page? Is the image in my brain the same as it is in your brain, to make sure that we're both going to get it right?
Yeah. So I'm curious, with like rhinoplasties and things like that, patients will bring in pictures of celebrities that, they want this nose or those eyes or whatever. Is that the same with breasts? Do people bring in pictures of celebrities and say, like, I would love this cleavage or I want this size?
Yeah. And as a matter of fact, that's how I work. I basically tell them, look, don't tell me you want to be a D cup, because in my looking at your body, I have an image of what a D cup should look like. It may be entirely different than what you're thinking. So the best way for us to be on the same literal page is for you to bring in pictures of breasts that you like and breasts that you don't like. And I mean the kind that you see on most plastic surgeons' websites, the ones that go from, neck to belly button, that are nude, because I tell them, look, I want to know what you want to look like when you step out of the shower and look in the mirror. I don't care what you want to look like with a bra or a bathing suit on, because some of these bathing suits can make men look like D cups, right? I mean, so I want to know, what are you going to be happy with when you look in the mirror without your top? And the best way to do that is with pictures. And sometimes I'm surprised, somebody who comes in, who's like, well, I just want to look natural. We'll bring in a picture, say, of an old picture of Carmen Electra. And it's like, okay, well, that's a little bigger than I was thinking, but that way I can adjust my thought process as to what I need to do for this person.
Yeah. So that's also a great way to pick your doctor, right? Is to look at their before and after pictures to see their work.
Yes.
Okay. So do you have photos on your website?
Oh yeah, we have a lot of photos. Most patients, particularly non-face surgery patients, don't have a problem unless they have like an identifying tattoo or something. And they're like, oh no, I don't want my friends to see that. But most patients, when it comes to body work, don't have a problem with us posting those and sharing those with other patients. And some patients may say, look, I don't want it on the general website, but if you want to put it on your computer so you can educate patients and let them look at it, then they're fine with that. So we have a whole variety of people. But yeah, I think looking at a website is important to see what kind of work they do. But more important, I think, is meeting the physician. Make sure you have a connection. And then probably even the most important thing is the office staff. I've been blessed with a great office staff that patients are really, really comfortable with. And they're like, wow, if they were this nice even before I did anything, I imagine they're going to be helpful afterwards. And they are. I mean, the reason I get so many 5 stars, I think, is because of my office staff.
Yeah.
Really, really good and attentive, and they really care about the patients.
Yeah. So is there an average size, or if someone just wants to go larger, it really just depends on the patient's body, right? Or do you find that you kind of get a similar request in your area?
Yeah. Well, I think, when I was in training and everything back in whenever it was, the joke was, and it may still be true. The joke was that in Texas they go bigger. So, if you were practicing in Texas, you had to anticipate you were going to use the larger end of the spectrum of implants, whereas in California, it was more the mid, right? I'm finding that in my practice, too, that the majority of women, unless they're really young or unless they're exotic dancers or something like that, tend not to want to be too showy. So a lot of women will come in after they've had 1 or 2 kids and they're done and they breastfed and they just lost all the volume. They just want to get back to where they were.
Yeah.
For women over 40, I usually try to convince them to go proportional rather than larger, because as men and women get older, you start to put on a little bit more weight, and larger breasts can make a woman look older, more matronly, less athletic. And so we try to keep the breasts so that it fits the body nicely. And it looks like what we want people to go is, did she have something done? Not like, oh my God, look at her. Yeah. So that's our goal, is to try and make people look proportional. Now, if somebody says, no, whatever the largest size is, I want you to put those in. If they will fit, I'll do that because that's what they want. But it takes a lot of time to kind of, like I said, circle around and figure out exactly what they want. And that's why pictures really help not only the woman to look at, if she thinks, oh, wow, I want to look really done, she'll look at some of the pictures that look really done and she might go, ooh, maybe not. Maybe I want to look a little more natural. So that really helps us hone in on what they want.
So how often, you mentioned if she wants the biggest implant, you will do that because that's what she wants. But how often are you advising against what the patient thinks they want?
Well, I generally don't advise against it. I just try to gently lead them in a different direction. But if we see that they're committed to that, and what they're committed to is not irrational, then we'll go ahead and do it. It's a little different than some other kind of surgery because for the most part, other than perhaps the aesthetic result, you're not really going to do any harm, whether you put in a 400 or a 600 implant. I just may not like the way they look, but if they're happy with it, then that's just the way it is, right? We try not to dictate to the patient because I'm not doing the surgery on me, I'm doing it on them, and I want to give them what they want.
Yeah. So what are the options for going larger? You can use implants, and then there's also fat. But I would love it if you could tell us the difference in the type of result you're going to get from each one.
Well, you know, fat transfer is a big thing now, and I do a lot of it in my breast reconstruction patients, my cancer patients, because it really helps enhance and smooth out some of the irregularities that you can get after a mastectomy or lumpectomy or something like that. But for augmentation, I think it has a much more limited use right now. There's some things coming down the pipeline that may make it a little bit more useful. But most of the women that we see that want a breast augmentation are kind of small like you. And there's not a lot of extra fat that you can borrow, because you always want to use extra fat. You don't want to use fat that you need to give you that nice smooth contour, right?
Yeah.
So, you know, to get a reasonable enhancement, you need a reasonable amount of fat. Not all the fat survives when you put it into the breast.
Right.
So what a lot of surgeons are doing is they're doing a combo. If somebody has some extra fat and they want liposuction as well, you can maybe use a smaller implant and put a little fat in to make up the difference in volume. So you have a little combination of that. And that can sometimes give you a little bit more natural result, a little less reliance on the implant to give you the look that you want, and using your own body to do that. But as a standalone thing, it's rare that you can get a significant augmentation unless somebody has a lot of extra fat.
So if you use the combination approach, like you just said, with fat and an implant, what if like 60% of the fat dies and goes away? Then are you having to go in and do it again?
I mean, certainly that's a possibility, and you have to warn patients about that. You know, most surgeons, I think nowadays, are getting somewhere between a 50 and 70% survival rate of the fat, because we've learned now over the years not to just, you know, jam it all in at one place. You really feather it out in small threads so that oxygen and blood can get to the fat and keep it alive.
Okay.
And so, you know, you can kind of, you know, get an idea that if I'm putting in, say, 150 cc's of fat in each breast, I'm going to count that as maybe 90 or 100 cc's. So I'll choose 50 cc's more for the implant to try and make it balance out better.
That makes sense.
Yeah.
So, you know, I'm really also curious about the technology nowadays that you can use to pick out your implants. Have you found that with these recent, you know, the apps and you know, there's now like these AI, you know, where you can actually, like, it looks like your body with like the boobs, and you can like adjust the size on yourself on the iPad. Is that helping you tremendously, or how have you adjusted to that?
Yeah, I mean, it's interesting. We used a program for several years, and of course they've evolved, so they're actually a little better than the one we used. The one we used took a little extra time to kind of get it done, but we found over the years that consistently using just conventional photographs of other patients and stuff like that, again, similar body habitus. So we have patients who are thin, where you can see their ribs here. We have patients that have a little bit more body fat and are maybe in the more normal weight range for them. And then we have heavier patients. And so based on the patient that we're seeing, we try to focus them on the pictures that match their bodies the best. And so over time, we've found that seems to work better. There's a lot of offices that use that technology. And like I said, we tried it, and, you know, it was fun, but I don't know that it was all that helpful. There's also people that use the bra stuffing method, which I don't use, and I never have used, because I don't feel that's accurate, because the implant sits in the bra loosely. And it's sort of a misrepresentation, I think, of how it's going to look, because the implant is a little bit compressed once it's in the body. Plus the fact that, like I said, I don't care what they want to look like in a bra. I only care about what they want to look like when they see themselves in the mirror.
Yeah. So in terms of cleavage, because I think this is such a, you know, we get a lot of questions about, well, I really want to have this cleavage that looks like natural breasts, but that is very difficult, if not impossible, right, to achieve with implants because of the way they sit?
No, not necessarily. What it really is based on is the anatomy of the woman's breast. So if there's a really wide space between the breasts, it becomes more and more difficult to pull the implants in more closer to the mid part of the chest. without it going outside the boundaries, the anatomical boundaries that that woman has for her breasts. And then you can get into trouble. I mean, there was an actress, I'm not going to name her, that was in a show back in the 80s that was very popular. And her cleavage looked like a triangle. You know, it was basically like this because they tried too hard to give her. And so, you know, we kind of advise people. And what I do is I generally will push the breasts towards the middle and get them as close as I think we can get the implants. And then I say, look down. That's about the amount of cleavage that you're going to have in terms of how close it is and how full it is. But no, implants can create nice cleavage if the anatomy is there.
Okay. And is it most often there, or is it not?
Again, it depends on women that have basically either totally empty or, more importantly, sort of underdeveloped breasts. It's much harder. But on a lot of women that have lost their breast volume because of breastfeeding, they may have had the volume there. And so, again, you can kind of see that. Again, if you push them together, you can say, oh, yeah, there's breast tissue that's sliding all the way over there. We should be able to have nice cleavage on that. So it's a very individual thing. And women that have larger breasts, as long as they're fairly close together, well, that's easy.
Okay.
Yeah.
So what is, with a lift, how often are you performing a lift without implants versus with implants?
Again, that depends on the volume that the patient has.
Okay.
So again, a lot of women that have breastfed and lost their pregnancy weight and things like that, they tend to lose some volume in the breast. And they generally will need volume enhancement as well as a lift if they've developed drooping afterwards. Okay. But there's some women that come in that had normal sized breasts, say a nice mid to full C cup. They've just aged either after breastfeeding or just, you know, heredity or whatever. And on a lot of those patients are like, look, I don't want to be any bigger. I just want my breasts back up where they were. Yeah. And in those cases, you know, we will just do a straight lift. Now, there's also some patients that have a tremendous amount of sagging that is going to require a more extensive lift, where you have to get much more aggressive by freeing up the breast tissue and really moving it up on the chest and tacking it down and removing maximum amount of skin. So in those patients, I will very often recommend a two-stage procedure. So I'll say, look, let's maximize this lift. Get that breast up as high and tight as we can so it looks really good and perky. And then afterwards, if you decide you want volume, we can always slip an implant in there. But when you're putting in an implant at the same time you're doing a lift, the lift has to be done more conservatively, because otherwise you can disrupt the blood supply to the nipple and it can be a nightmare.
So what happens with the nipples when you do a lift like that? I'm curious, because or any lift really, you have to reposition everything?
Yeah, the nipple stays attached in most cases to the breast tissue. Okay. So what you're doing, it's almost like peeling an orange. You're lifting the skin up and you're exposing the breast tissue with the nipple on it. And then you sort of shape it and move it up, because it's usually hanging off the chest or off the muscle. So you want to sort of bundle it up, bring it up, anchor it up higher here where it belongs, and then wrap whatever skin you need around it and get rid of the rest of the skin. And for the more severe cases, you need what's called an anchor lift, where you have the incision that goes around the nipple, straight up and down, and then underneath the breast. So it looks like an anchor. In some cases, if you're doing it simultaneously with an augmentation, or the drooping is not that severe, you can get away with what's called a lollipop lift, where it's basically a scar that goes around the nipple and straight up and down. So it looks like one of those Tootsie Pop kind of things. So there's a little less scarring, but you do get a little less lift out of that. But if you're doing an augmentation simultaneously, you don't generally need as much lift, because the implant itself will help with the lift.
I love how you make it sound so easy. You're like, we just peel it back like an orange and move it up.
That's 30 years.
Wow. So do you find that your breast lift patients are like more satisfied because it's such a dramatic difference because it's not just size, it's also positioning. I can't even imagine what that must feel like to look in the mirror and see that change.
Yeah, it's a similar procedure is a breast reduction. A breast reduction generally is an insurance type of procedure for really heavy, droopy breasts, and that actually is probably the highest patient satisfaction surgery, certainly that I do, for two reasons. One is it alleviates the discomfort and shoulder pain, neck pain, that kind of thing. But more importantly, it makes the breasts more youthful. And again, as you're describing, now they're actually seeing their nipples pointing out, and the breasts are up where they belong instead of hanging down on their tummies and stuff. And it's the same thing with a lift, depending on how severe the aging of the breast is, or the damage from breastfeeding or massive weight loss or whatever. The more difference that you create, the more amazed the patients are. But yeah, it's got a very high patient satisfaction.
So with a breast reduction, do they, how much smaller are they going typically?
Well, again, that also there's so many variables in that.
Okay.
If it's cosmetic, then we can go, let's keep them as large as they want. If it's an insurance case, they have this graph that you have to use that uses the height and the weight of the patient to calculate a surface area. And then based on that surface area, it tells you, oh, you have to take 500 grams off each breast or 800 grams off each breast. So if it's an insurance case, I generally will tell patients, I don't know for sure, but you could end up somewhere in the mid B cup range based on these numbers. And they're going from a double D. So it's sort of like, are you okay with that? Because if you are, then great. If you're not okay with that, then either you need to lose some weight to get that number to come down, because we can't change your height, or you need to consider doing it cosmetically, where I can take off as much or as little as I want. But it's amazing because a lot of women that have really large breasts and all the symptoms of the bra straps cutting into the shoulders, they're like, whatever. I don't care what size I am, just get these things off.
Yeah.
And generally, like I said, those patients are unbelievably happy, almost no matter what size they end up being. And I work really hard to try and keep them as proportional as possible based on the limits that the insurance company will set on it.
Yeah. I mean, I imagine too, the amount of weight that you're taking off of them is going to make their whole body look smaller.
Oh, absolutely.
Right?
Absolutely. I mean, I had one lady several years ago where I took a total of 10 pounds off of her breasts. I mean, imagine having 10 pounds of dead weight hanging around your neck every day. And that's why for some of these insurance companies that deny it, I have to call in and argue with the doctor. And I say, listen, here's what you need to do. Go get a couple of 2-pound weights, put them on a rope, and walk around the office with that thing hanging off your neck. And then you tell me the patient doesn't need it, right? So yeah, it really is life-changing in terms of the activities they can do, the clothes they can wear, rashes they were getting in the summer are gone. It really is transformational.
Yeah. So what is the surgery? Is that I'm talking about the recovery and the after, what does that all involve if someone is doing a reduction?
With a breast reduction, typically I tell patients that depending on the kind of work that they do, they can usually go back to work within 10 days to 2 weeks. They're up and about that day. I mean, it's done as an outpatient procedure. So they go home the same day. We have them get up, walk around. I personally leave drains in for about 4 or 5 days. So during that, they can't shower. But then afterwards, the recovery takes time to do unrestricted activities. I usually tell people within 6 weeks, you can do whatever you were doing before. But until that time, it's sort of a graduated release of privileges of things that they can do. But most people are off pain pills within 3-4 days. They can drive after that. So it's not that bad. And it's certainly not one of the more painful procedures that we do. So, yeah.
I mean, I think that sounds a little scary, but I imagine that, like you said, those are some of your most satisfied patients.
Oh,
And
absolutely.
I bet you probably don't have anybody that's like, oh man, recovery, I wish I didn't do it.
Right. We've never had that.
Yeah, I bet. So what about the people who have asymmetrical breasts? What are their options?
It's the same sort of thing. I mean, there's a wide spectrum of asymmetry that people present with. If it's minor asymmetry, and let's say they don't need a lift, then they just want an augmentation. Well, then you just use two different size implants, and that generally will help correct that in terms of volume. If you have patients, we've had the other extreme is something called Poland's syndrome, where somebody has maldevelopment of the breast and the chest muscle, and that comes in a variety of stages. In those situations, you have to do, and the other breast may be large and droopy. So in those cases, you have a lot of work to do in terms of enhancing and reconstructing basically the one that didn't develop, and then shrinking and lifting the other one to try and get them to match. So that's where the art of plastic surgery comes in, as opposed to it being sort of a scientific technical thing. Now you have to sort of say, wow, how am I going to get these to kind of look similar? And those are fun cases, but they're also a lot more challenging.
Yeah, I think I read a statistic that like 40% or more of women like have some asymmetry in their breasts, right? But it's
Oh,
probably just very subtle.
yeah, it's much more than that, actually.
Okay.
And so sometimes when I'm seeing a patient, and I'll point out to them, oh, you're a little bit asymmetrical. This breast is a little larger than that. I forget to chime in, and thank God, usually my office manager, Kate, is there, and she'll say, oh, and that's normal,
Yeah.
so that the woman doesn't think, oh my God, I'm a freak.
Yeah.
I would say it's more than 48%. I would say it's probably more like, in our practice, 75% have some
Wow.
degree of asymmetry. It might be that one nipple is slightly higher than the other, or the creases are a little bit off, or the volume is slightly different, but it's small enough that minor things can fix that.
Yeah.
All the way to the other end of the spectrum, like we just talked about.
Yeah. So the rule used to be that you had to replace your breast implants once every 10 years. Is that still something that you follow, or what has changed?
Well, actually, that's never been a rule.
Okay.
When silicone implants were re-released onto the market, there was a lot of pressure against the release because there were a lot of people talking about how unsafe they were and everything. So the FDA had to come up with something. And so the idea was, all right, well, we don't really know how long these implants last. So let's just pick a number. So they picked 10 years. But what they meant by that was that it's not a timer that the minute you have them put in, you have to, I got, 3 years left. It's not like that at all. The recommendation is after 10 years, if you haven't had any problems with your implants, if after 10 years you're having another surgery on your breast, let's say now you need a lift because you had 2 kids or something, then they say, well, go ahead and change them out then. But if you're 12 years out and you've had no problems and there's no evidence that they're ruptured and there's no capsular contracture, there's none of that going on, you just leave them in.
Yeah. What is capsular contracture? Can you explain that for everyone?
Yeah, capsular contracture is one thing that we actually really don't understand. We have some ideas of what might cause it. What it is, it's abnormal scar tissue that forms around the implants. Normally, when you put an implant in, your body will wall it off with a very thin scar, and that forms a nice pocket that holds the implant in place. But in rare cases, and it depends on circumstances and that kind of thing. In my practice, it's about a 2 to 4% risk. One side or both sides, the scar tissue thickens and begins to shrink and can displace the implant. It can be uncomfortable and that sort of thing. We don't know what causes it. There's suspicion that it might be related to a low-grade infection, which is why I use antibiotics for this surgery. It might be related to blood in the pocket after the surgery, which is why most surgeons that I know irrigate the pocket where the implant's going to be until it looks the same going in as coming out. And so we do all these things to try and alleviate the risk, but it's never 100% that you're going to get away with not getting it. And you can't tell which woman's going to get it and which one isn't. There's no statistics that show, oh, if you're this, you're more likely to get it.
Yeah. So what are the signs that someone might have it?
Well, it can happen a month after surgery, or it can happen 22 years and 3 days after. And what it typically is you begin to develop a little tightening, where it just feels, this side feels a little tighter when I go like this, and then over time, what can happen is the implant can start to get distorted. And we've all seen women at the beach in bathing suits with what look like two balls on the chest. That generally is not bad plastic surgery. That generally is capsular contracture. And so it becomes more obvious the worse that it gets. Yeah. And the only treatment for it really is to go in and cut the scar tissue out. There is a medication that has been shown to potentially stop the development of it if you think that it's beginning to happen. It's called Singulair, and it's an asthma medication.
I take that.
Yeah, so there's no ill effects from it for most people, and you put them on 10 milligrams a day for 2 months. Yeah. And in a lot of cases, it can stop it and prevent it from happening.
Yeah, I take that for my allergies.
Yeah, there you go. There you go. Yeah.
Interesting. I had no idea that was used for that.
Yeah. It's it doesn't work all the time, but in my practice, we've seen it work in many cases. That's
like so cool. It's so fascinating about medicine and what you guys do, because you find these medications, it's like spironolactone, it's like used for, like, I think it was like a blood pressure medication, and now it's like used for like hormonal acne. It's right. Just like so cool what medicine. I'm just fascinated by what you guys do. So there's been a lot of talk about breast implant illness, and I know that that's something that you're very well versed in, and I would love it if you could talk a little bit about where we are with that right now, and what patients should know.
Well, there's two things that people sometimes conflate. And one is breast implant illness, and the other is breast implant associated ALCL. ALCL is anaplastic large cell lymphoma. They're two separate things, and we can talk about them one by one. Breast implant illness is the one we understand the least, and there's not a lot of good, solid science out there about whether it really exists, and about whether the treatment that we can offer is going to make a difference. So breast implant illness is very much like chronic fatigue syndrome, where people will have lethargy, they could have GI problems, get headaches, they're fatigued, they can lose hair. There's all kinds of systemic issues that occur. And there's a large movement now that is pinning those things on breast implants. Yeah. And again, we've seen a lot of patients over the last 4 or 5 years that have this. And so, the question is it due to the implants? Because in most cases, the implants are intact. So it's not even like they're ruptured and maybe some silicone is going somewhere. Some people think it may be an autoimmune sort of response. But from 1992, for about 10 or 11 years, we had to do a study, and implants were severely restricted, silicone ones, to find out if silicone was causing autoimmune disease, like lupus and scleroderma and rheumatoid arthritis and even MS. And so we had to do these studies where we did these very tight follow-ups on patients. And if they complained about the slightest thing, like, hey, my teeth itch, we'd have to send them to a rheumatologist to have them worked up to see if anything was going on. Wow. This was a study that was done worldwide. And it basically concluded that the risk of developing one of those autoimmune diseases was the same in women that had implants and women that didn't, which is why the FDA decided to release the silicone implants for general use again. So, we don't have a lot of data to support the idea that the implants are causing it. Nevertheless, these women are looking for help. And even though a lot of the results of feeling better are anecdotal, if a woman is like, I want these out because I think they're causing my problem, um, we will do that. And we just really try to tell them that, look, I hope your symptoms go away,
Yeah.
but they may not. And you need to understand that this may be due, even though all your tests are negative, because you've been worked up for all this other stuff, you may not feel better, because also a lot of the women that we've seen are working women with 2 or 3 kids, stressful lives, all that kind of stuff that can cause anxiety, GI problems, hair loss, all the things that they're complaining of, right? So
Right.
it may be a lifestyle thing that's creating the problems. But again, we don't poo-poo it at all. You know, if they end up feeling better afterwards, we're really, really happy. Um, I would say that in our experience, I would over 50% of the women feel better, uh, but a lot of those feel better for 6 months, and then they start to have issues again. And so again, that makes me wonder if some of it is their lifestyle.
Yeah.
But there are some women that say, this is the best thing I ever did. I'm so happy they're out, and I feel much better, and that's a success. And
Yeah.
I'm happy about it. But right now it is sort of a nebulous disease that we don't really understand. And I think it's our obligation to do what women want, as long as we make it clear to them that this may not help.
Yeah.
The other one is the one we know more about, which is the breast implant associated ALCL, or anaplastic large cell lymphoma. That is a cancer. Anaplastic large cell lymphoma can happen anywhere in the body, but in a small number of cases, it's been found around in the scar tissue around breast implants. And I think as of now, there's still less than 1,000 cases worldwide out of the tens and tens of millions of women that have implants in. And all of them have been associated with textured implants, which are rough on the outside rather than smooth. And almost all of those have been associated with one company's implants. And so the FDA is having us as a society do some research, and we started a registry. So anybody who does get a patient puts that data in, and hopefully we can learn more about this. But it's such a small proportion of the number of women that have implants in, that even though we know what it is, it's a cancer. And by the way, you can pretty much be cured if it's caught early enough and you take all the scar tissue out. Since they started doing that, the death rate has gone almost down to zero from that disease. But typically that presents after about 8 to 10 years, where a woman will suddenly get swelling in one breast or both. And so the protocol that most of us follow now, unless there's definite cause that we can think of, like trauma, oh yeah, my breast started swelling. What'd you do? Well, I dropped a TV on my breast. Oh, well, it's probably that, right? But if they're like, no, I've had no trauma, I haven't had any dental work, which could cause an infection, I haven't had anything that could have caused that, then we slip into this ALCL protocol. And typically, if we can, we try to get some fluid extracted, send that to the lab to be looked at for certain types of cells. And if they find those cells, then obviously we go in and we do a complete resection. Some people call it an en bloc resection. Other people call it a total capsulectomy. But the point is, you want to get all the scar tissue out. If that's negative, you still tend to do that, and you still send the specimen to the lab, but it does give you a little pause where you can take a little more time to kind of try and get this done.
Yeah.
So those are two different things: the breast implant illness and the BIA LCL.
And for anybody who is, these are a lot of terms we're using here. So if anybody is confused or wants to know more information on this topic, you can check out the doctor's website. You can also check out newbeauty.com. We've written about this subject a lot. And I think
you guys have been really on top of this. That's great.
Yeah, thank you.
Yeah.
I mean, we've really tried. We don't want there to be these fear mongering and scare tactics and all these things. We just want to educate everybody so that you know what your options are. And so if anyone wants more information, we'll be saving this live on our IGTV, and then also you can check out go to board certified doctors' websites like Dr. Pollack and newbeauty.com. So, another thing that I want to learn is what is the maintenance with breast implants? How do they affect your mammogram, and how often do you have to come back and see your doctor to make sure everything's good?
Um, certainly in the beginning, we had patients massage the implants a lot, and they're willing participants. And as their interest fades, we try to convince their significant other to massage the implants. But I think the massaging is most important in the early stages to kind of keep the pocket stretched and that sort of thing. And afterwards, it's probably a little less important. But with mammograms, they do have to take modified mammograms, where instead of the normal, vertical and horizontal smash that they do, they have to do some oblique ones as well to make sure that they can see the majority of the breast tissue. And if you go to I think it's ACR certified mammogram center, they know about implants. And here in California, of course, every other woman has implants, so they're really well versed in that. But they take a little more care. I mean, one of the reasons that implants get ruptured is because of mammograms. There's no question about it. Wow. But if you go to a place that takes care of a lot of patients that have implants, the chances of that happening are much smaller. Yeah.
And you mentioned, textured implants. Our textured implants are still being used though, right?
Well, it's funny that they're being used less and less now.
Okay.
Since we don't understand it, even though it's basically one company's implants, textured implants, that is what the FDA is focused on. Unless somebody needs a textured implant, a lot of people are backing away from them. Even now, tissue expanders that we use for breast reconstruction that were all textured are now smooth, and I'm using smooth ones. And so, it's just, we're erring on the side of caution since we're kind of stumbling down a dark hole without a flashlight. We want to be as careful as possible. Right. That we're not doing something that in the long run may be a problem for the patient.
Right. And I just want to also, something that I want to make sure I'm correct on this, but aren't silicone breast implants one of the most studied or the most studied medical device ever?
Yes.
Okay.
Yeah. They've gone through the gauntlet. And like I said, we had that 10-year study where, we had to check everything. And there were reams and reams of paperwork that we all had to do if we were using gel implants. And the other thing is that actually helped the implant companies too. Right. Because, one of the things we were finding is back in the 90s, there was a little higher rupture rate of implants because of the quality of the shell and that sort of thing. And so over time, not only has the quality of the gel, the silicone gel, which is a lot more solid now or cohesive than it was back then, the shells are really substantial as well. So, you can squeeze an implant like this till the cows come home and nothing's going to happen to it. But if you put it on the floor and jump on it a couple of times, it'll break. Yeah. And it's like, well, that's not really something that hopefully is going to happen to a patient, where she sustains that kind of trauma.
Right.
So, yeah, the technology's gotten better. I've seen some things from some of the implant companies, which are proprietary, so I can't talk about it in detail. But some of the new implants they're coming up with are just brilliant in terms of, I think, safety, in terms of natural feel, in terms of longevity. And then there's other companies that are working on this matrix that you'll be able to put into the breast rather than a solid implant. And into that matrix, if somebody doesn't have enough fat, you'd be able to inject fat into that matrix and the breast tissue would grow into it. And so now you'd have an augmentation with a much more natural situation. So there's a lot of really interesting stuff coming down the pipeline here. But for now, yeah, I think the current generation of implants that are out there are as safe as anything can be. And as long as you go to the right surgeon and obviously if you're a kickboxer or a surfer, your risk of rupture is going to be higher than somebody who doesn't engage in those kind of activities. So as long as you kind of are aware of it and just kind of do reasonable checking. And then our office tells patients, I don't care if I haven't seen you in 5 years. If you have a problem that wasn't there before, you call our office, you come in, let me take a look at it. And whatever we have to do to diagnose what the problem is, we'll do.
Yeah, I love that. I mean, I think you hit the nail on the head. It really is. It's down to doctor selection, surgeon selection. I think, that's what, we pride ourselves on at New Beauty. If anybody who wants to grab an issue, you can find all of our trusted doctors. Everybody is vetted and board certified, and it really is so important. And like we said earlier in the live, check out the doctors before and after images. If you aren't seeing images of things you like, you probably shouldn't go to that doctor.
Yeah, that's right.
Yeah. So, check out their qualifications, do your research. It's your body. You really want it to be, if you're going to make the investment in yourself, make a good choice about the surgeon. So, I think, is there anything else that you want to add?
No, I think the most important thing, and it I think applies to the times we're in right now, is that there's a lot of information on the internet, and you have to use a little bit of you have to be a little careful in what you're reading, and check the source, whether it's about breast implants or whether it's about COVID. Check the source of the news that you're reading, and make sure that it's a site that is legitimate. Like for plastic surgery, you can go to the American Society of Aesthetic Plastic Surgeons. You can go to the American Society of Plastic Surgeons. You can go to New Beauty. You can go to some places that vet the information that you're getting, so that you can fairly rely on it. Same thing with the NIH regarding COVID. If you go there, you're getting the latest scientific information that you can get. So that's what I would say about any research you're doing about anything that you want, including breast lifts and augmentation and all that. Go to sites that are legitimate and really do the work to get you the proper information.
Yeah. Nope. You got it right there. That's exactly
there you
it. Go. That's what we stand for. So, thank you so much. This has been such a great conversation. We will be saving it on our IGTV. And if anybody has any questions, your Instagram handle, it's not showing up for me, is Dr. Pollack?
I think it's Dr. Larry Pollack.
Yes.
Yeah.
So definitely go online, get information from a credible source. And thanks for tuning in today. It was great to see you. And hopefully, we will connect soon after quarantine's over, and everybody stay healthy.
All right. Take care. Thank you.
Bye. Thank you.
Bye-bye.